Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto. I'm the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. And today our topic is an important one for the males in our community. It's regarding prostate cancer. Our guest is Dr. Stephen Terranova, who's a board-certified urologist who is working for Brandywine Urology Consultants here in Delaware. Dr. Terranova got his Bachelor of Science degree in chemistry from the College of William and Mary. He also received his master's degree at the same college. He received his medical degree from the Medical College of Virginia in Richmond. He did his general surgery internship at the Medical College of Virginia, as well as his residency in urology. He did his fellowship in laparoscopy and endourology at Duke University Medical Center. He is board certified in urology, as mentioned above. He has many references. He has many publications. And if I read them all, we would not be able to continue this until tomorrow. So we're here today to talk to Dr. Terranova. Welcome, Steve.
Thank you. Thanks for having me.
You're welcome. Before I tap into your expertise, I would like to give a brief introduction. Prostate cancer is the most common non-cutaneous cancer and second leading cause of cancer-related deaths in American men, with an estimated 250,000 new prostate cancer diagnoses yearly and 35,000 prostate cancer deaths, according to statistics from 2022. I think they've maybe changed a little bit, but I'm sure not too much. The clinical incidence, however, does not match the prevalence of the disease. Autopsy studies have shown that 40% of men over 50 have prostate cancer, though it was not discovered except through autopsy studies, when the cause of death is something unrelated to prostate cancer. Its prevalence increases with age, with approximately 30% of men 60 to 69 and 67% of men ages 80 to 89 having it discovered at autopsy. Most of these discovered cancers are small organ confined without having regional or metastatic components. The global prevalence of cancer of the prostate at autopsy is relatively consistent, yet the clinical incidence varies considerably, with the highest incidence in North America, Europe, the Caribbean, Australia, South America, and the lowest incidence in the North African area and Asia. Its highest incidence is in the black race, with a strong family history as also being a higher incidence of prostate cancer, and interestingly, a history of high dietary fat intake. And now to you, Steve. First question. Are there any reasons why the disease seems to be higher in the developed countries, or is it just due to the higher detection rates in these countries?
I think that has to do with diet, like you said. Mm-hmm. I mean, there was a study where people in Japan were not getting prostate cancer, and then when they moved here, they started getting prostate cancer. Mm-hmm. You know, in Japan they eat a lot of fish, so it's a lot of fish, protein, not carbs, foods. Less carbs, less sugars, things like that. And I think so a lot of that has to do with it. It also could be a genetic component as well, too.
Correct.
Yeah.
I'll tell you, the American diet is not very good. We've seen a lot of very high rates of cancer here in America when it's not like that in other developed countries where some of their diets are much better. Okay, what is the signs, and are there any, and symptoms of prostate cancer, and does a digital rectal exam alone is a method of detection?
So I'll take that first question first. That I tell my patients all the time, the reason we need screening is there really are no signs or symptoms until it's too late, right? So that's why it's so important to get your PSA checked every year, to get a prostate check. It doesn't have to be every year with the prostate check as long as you have a baseline and it's your PSA is remaining stable. I tell my patients all the time, you would never drive your car 100,000 miles without getting the oil changed or the tires rotated, right? So same thing here. You won't know about it unless you check. And that's the only way to really find clinically
the cancer.
Significant prostate cancer, yeah.
On that same topic, how accurate is the digital rectal exam?
I mean, it depends on experience, like anything else, of course. We have people that I've found prostate cancer only because of that. I have one person in particular I can think of that if we hadn't done his hadn't done his prostate exam, we would never have known about his very aggressive prostate cancer that he had. Because what can happen with aggressive prostate cancer, PSA is just a protein that prostate tissue makes, right? So if you have very aggressive prostate cancer, you can have very undifferentiated cancer and it won't make PSA, so you can have a low PSA.
Wow.
So it's not very common, thankfully, but I think it's important to have the prostate check. You don't want the prostate check to be your only form of screening, though, so you need the PSA also.
Okay, you just mentioned that. So, okay, Joe Blow didn't get his prostate checked, didn't have a digital rectal exam. PSA's 2, nothing bad, but yet he's carrying a very aggressive cancer.
It's possible, yes.
We know that the prostatic specific antigen, or the PSA, is commonly used, and the level that we detect greater than 4 is considered concerning, correct?
Mm-hmm.
Okay. Sometimes we overlook that test, and it can be very specific for prostate cancer. But why don't we use something like a dedicated MRI for the prostate, which is pretty specific in finding it?
We are doing that. So let me back up a little bit before we stop talking about PSA. PSA can be different depending on the patient's age, right? So you can have a PSA of 2.7, but if you're 50, under 50, that's a significant PSA for somebody that age.
Understand.
You know, so as we get older, we'll accept a higher PSA as quote-unquote normal, right? So we also look at PSA velocity, where how fast does the PSA change, right? As you know, you can have a PSA one year, say your PSA is 1.4, and then the next year you come back and it's 2.8. That's significant.
That's a big
right?
big
So
difference,
it's normal for it to go up slightly as we get older, you know, maybe by 0.2 or 0.3, 0.4 maybe per year. But once we start seeing a more steep rise, that gets our interest.
Understandable.
As far as the MRI goes, we are doing a lot of MRIs now. MRI has been really helpful in detecting clinically significant prostate cancer. So a lot of what we do now is if the patient can have an MRI, right, safely, we'll do the MRI. The only problems with MRI sometimes is if you have a hip replacement, it can cause a lot of scatter,
Right,
which
from
makes
the
it
metal.
hard for the radiologist to really tell if there's a significant lesion there. You know, obviously you can't do it if you have an implantable metal device, but we've been using what's called the PIRAD scale with the MRIs, and that goes from 1 to 5, where 1 and 2, we don't do anything. 4 and 5, we do a biopsy. So if they see a lesion that's graded as a 4 or 5, we do a biopsy. There's also 3, which is right in the middle. Sometimes we biopsy, sometimes we don't. I just had someone today, he's in good health, he had a 3, I recommended a biopsy.
Okay, so a 1 and 2, does that mean they have a cancer but it's not worth a biopsy, or is it too small to biopsy, or what?
It's possible. It could mean there's nothing. I'm glad you asked that because I was just about to explain that. It could mean there's nothing there, but I also explain all the time to people that an MRI can miss a low-grade prostate cancer. Low-grade meaning less aggressive. So, but I also explain to them if you had that, we'd likely just be keeping an eye on it rather than treating it.
Right.
So, yes, the negative MRI, i.e. MRI PIRADS 1 or 2 is good, but we still would keep an eye on their elevated PSA.
Can a PSA be elevated other than for cancer?
Absolutely. There are a lot of things that falsely elevate the PSA. One of them is just having a large prostate. Right? So, like I tell people all the time, PSA is just a protein that prostate tissue makes. If you have a bigger prostate, it's going to make more protein. So, if you have, say your prostate's 100 grams, we use PSA density, right?
Okay.
So you divide by 10, they could have a PSA of just 10 as being normal for them with that size prostate. If your PSA is 200 grams, like I saw someone today, their PSA could be 20. You know, so it's a little confusing in those patients when you have such a high PSA, but you feel a little more comforted when they have a large prostate.
And they don't have cancer, but they have a large prostate.
So that's one thing that could explain it. There are a lot of things I tell people to avoid before getting a PSA because there are a lot of things that can falsely elevate it. Riding a bike, a motorcycle, a lawn tractor, anything where you're bouncing up and down on your behind, that can falsely elevate it, right? Having intercourse or ejaculation can cause it to be elevated. That's why I always recommend that people avoid all those things for about 4 days before getting the PSA.
Mm-hmm.
Another thing that can elevate it is inflammation. We'll do a biopsy on someone and it'll show maybe not necessarily any cancer, but there'll be inflammation.
Mm-hmm.
And for whatever reason, either prior infection or whatever, inflammation can cause the PSA to rise and fall. Yeah.
Maybe riding that motorcycle into your office caused inflammation
Exactly.
to make the PSA rise also.
Exactly.
This is a very odd question. I'm pretty sure I know the answer, but I just want our listeners to hear it. Is there any relationship with human papillomavirus and prostate cancer? As we know, there is a relationship of human papillomavirus, or HPV, with women who get cervical cancer and oral cancers from HPV. Is there any relationship, or has any studies been done to see if there's a relationship between HPV and prostate cancer?
Not that I know of now. For us, as urologists, what we're concerned about with HPV is penile cancer, actually,
Right. Mm-hmm.
which is extremely rare, thank God. But it often occurs in people who are uncircumcised if they don't take care of it properly. So as long as they clean under there, keep it dry, the reason you get penile cancer is chronic inflammation under the foreskin. Mm-hmm. And certain types of HPV can lead to that.
But there are no relationships.
Not as far as we know right now.
It'd be an interesting study, I mean, that damn virus gets all over the place.
It's a troublemaker,
doesn't it?
that's for sure, yeah.
All right, I'd like to take a quick break now so we can identify some of the things that the Medical Society is doing in our break, and we'll be back shortly.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Okay, we're back from our break, and I'm Dr. Biasotto speaking for the Medical Society as the host of their podcast, Delaware Healthcare Reality. We're here with Dr. Stephen Terranova, who is a board-certified urologist in our area. And I've been asking him questions. He's been doing a great job answering them. I have another question for you, Steve. When prostate cancer is suggested from PSA elevations, digital rectal exam, or an MRI, a biopsy is usually performed in the cases that you mentioned earlier. Please explain how that biopsy is done.
Sure. So the traditional way to do the biopsy has been in the office, called transrectal ultrasound guided biopsy of the prostate. Mm-hmm. And basically what we do for that is the patient avoids blood thinners for a week before they do an antibiotic and enema prep just to prevent infection, etc. They lay on their side. We go through the rectum with the ultrasound probe, numb up the prostate,
right,
which really helps.
Sure does.
Really helps. And it takes about 3 minutes. We take 12 snips of the prostate, sometimes more depending on what's going on, and then they go home. So that's the first thing. Then once the advent of getting all these MRIs came about, now what we do with those is we can do what's called an MRI guided biopsy. Mm-hmm. Okay, and that's done at the hospital. It's done under sedation, like a colonoscopy. And once the patient is sedated, because it takes longer, it takes about 20, 25 minutes. Mm-hmm. So once the patient's sedated, go through the rectum with the ultrasound again and match the MRI picture to the ultrasound picture. Mm-hmm. And we biopsy those specific sites.
That's very accurate.
That we found on the MRI. And we do the rest of the prostate like we traditionally would as well. So it's much more accurate, I think.
I agree.
So
that sounds like
it's very good. Newer things that are coming about are there's a perineal biopsy.
That's what I was going to ask.
To avoid going through the rectum.
For our listeners who don't know what the perineum is, it's between the male genitals and the anus. So that's the perineal. Mm-hmm. Do you do many of that?
I've not done a lot of those yet. I've done it before. It's a little more technically challenging. We do have an infection rate with the others, but it's pretty low, especially with all the antibiotics that we do. But it does happen. The advantage, like I said, of the perineal is that it helps avoid infection.
Gotcha.
Yeah.
All right. As you know, I'm sure that there are numerous treatments alternatives for prostate cancer. Some of my patients say, I could do nothing, Doc. I could just sit around and wait. Please discuss these alternatives and tell me what your recommendations are for them.
Sure. I'll start with least invasive to most invasive. Mm-hmm. Right? So the least invasive thing you can do is called active surveillance. All right. So, and a lot of that depends on the age of the patient, their comorbidities, i.e., other medical problems that they have, and how aggressive the prostate cancer is. Right. So, what we do now when we get a prostate biopsy, should I discuss the Gleason score here?
Not yet. We're getting
okay. We'll get there.
Score.
Okay.
Let's get
so if you have less aggressive prostate cancer, we usually back that up now with a test called the Decipher test. We take the same tissue that's been taken out at the biopsies, we send it to another lab, and they look at it on a genetic level. And if that confirms low-grade disease, then we feel better about what we call active surveillance. Now, the Decipher is not perfect, but it does help guide us. So active surveillance is the protocol I use is I check a PSA every 3 months for the first year. And as long as that PSA stays stable, then a year from the original biopsy, we do another MRI and or biopsy. If that comes back low grade or less aggressive again, then I start checking every 4 months with the PSAs for a couple of years, and then an MRI or biopsy every 2 to 3 years. And then as we keep going, eventually we get out to 6 months. Now, anytime during that process, if the PSA starts rising or we feel a nodule or something, or the MRI shows more, we always would switch to treatment at that point.
Exactly.
But I have patients I've followed for 10 years or more. I have patients that I've followed for a year or two and then they need treatment.
Okay.
So
10 years, they haven't shown any...
No progression.
No progression of the disease.
And those are those patients you were talking about before that die with it,
Yeah.
not from it.
And found from autopsy only.
Exactly.
Okay.
So that's active surveillance. There's also what we call androgen deprivation therapy or hormone therapy, okay? Testosterone is an androgen. It's the male hormone. It drives prostate cancer. So if we take that away, it'll slow the cancer down, but it won't cure it. So I don't recommend that as a primary treatment for anybody unless they have metastatic disease or spread, right? So if they have spread of the prostate cancer outside of the prostate, that hormone treatment or taking away the testosterone with a shot or pill, that will slow it down, and people can go years and years like that, many years, especially with the new treatment that we have. We have testosterone from the testicles. That's the main source. We can block that with a shot or a pill, or by removing the testicles, which we don't do very often anymore.
I haven't heard
it's
that
not,
for a
it's
long
not reversible.
time ago, it was right.
It's not very common anymore. But also there's some testosterone that's made in the adrenal glands, which sit above the kidneys. They make adrenaline, they make steroids, but there's a small amount of testosterone that's made there, so we also would add that for total androgen blockade or total testosterone blockade. And in this case of metastatic disease, there's been shown to be some survival advantage to do that.
Okay.
We also give hormone therapy when we do radiation therapy sometimes because it helps the radiation therapy work better.
Okay.
All right. There's another thing called cryotherapy where we freeze the prostate. None of us really do it. We don't think it's the greatest treatment. So I just tell people that they have to know about it. And then it really comes down to radiation or surgery, right?
So it's a brachytherapy, which is seeding the prostate,
Yes,
right?
That's one way.
Then there's direct beam.
Correct. External beam, yeah.
But some people, when they hear the word cancer, they say they want it out.
Yes.
And if they insist, even though you say, you don't have a real aggressive one, do you want it out? Or you say, really, do you want to go that route? And they say, yeah, it's cancer. I want it gone.
I have plenty of people like that, yeah.
Well, the side effects of a total prostatectomy, in my experience with patients that have had it, is they have a real tough time afterwards. Incontinence is the biggest thing that they complain about. And when you've dissuaded them from maybe going that route and they do so, you have to explain to them, well, this is what you're going to be facing, correct?
So when I'm setting someone up for surgery, I have about a 25-minute discussion that I have with them about the risks of it. And the main things are incontinence, like you mentioned, and erection problems, right? Because the nerves for erection sit right next to the prostate. In the properly selected patient, though, a lot of those people, I have people that have been continent just after about 2 weeks, 2 or 3 weeks.
They got back to normal.
That's not the normal situation. But most people, especially if they're not overweight and if they're in relatively good health, most people eventually stop leaking after a few months.
Got it.
Yeah. And that's especially with the robotic surgery, because we do the robotic surgery with the smaller incisions, yeah.
Now, I know you do brachy or direct beam, too, and that's with the radiation oncologist you're affiliated with.
Yep.
Do you protect, anatomically, let me just go through everything for our non-medical listeners.
Sure.
The prostate and the rectum are very close together.
Yep.
There's a space between the prostate and the rectum. Now, if you irradiate the prostate, is it going to affect the rectum or the bladder? Or the rectum, let's call it the rectum. Do you do anything to protect these organs from getting effects of radiation?
Sure, that's a great question. Yes, we can do that. It's called Barogel. There's a gel that can be placed between the prostate and the rectum. It's more for the rectum, but I mean, I suppose it protects the bladder a little bit. But yes, we can do that. It's not 100%, of course. We have 2 of our partners that do that.
Okay.
Yeah.
Okay, that's very good to know.
Yes.
So patients out there, you might want to talk to your urologist about that when the time comes, God forbid, if it comes.
Correct.
Okay. The most common cancer discovered in the prostate is adenocarcinoma,
Yes.
is correct? And the biopsy report always discusses the Gleason score. Now, I have every patient in the world that has been diagnosed with prostate cancer, had a biopsy, says, Doc, explain to me what the Gleason score is. Can you explain to our audience what the Gleason score and how it is determined?
Sure. This is how I explain it to my patients. It's just a number from 1 to 5 plus another number from 1 to 5. All right. 1 is the least aggressive. 5 is the most aggressive. The first number is the most predominant pattern in each specimen, and the second number is the second most predominant pattern. So say you have a Gleason's 3 plus 4. That means most of it's 3 and some of it's 4. Okay. I also explain to patients that I've been looking at these things for more than 20 years. I've never seen a 1. 1 is too close to normal for the pathologist to call it.
Okay.
Also, in the thousands of these I've seen, I've only seen a 2 a few times. Okay, so really the lowest one you're ever going to see is a 3. All right, so if you have, say, a 3 plus 3, that just means all of it's 3. If you have a 3 plus 4, that means most of it's 3, some of it's 4. And we divide it into low risk, intermediate risk, and high risk, right? So low risk would be 3 plus 3 or lower. Intermediate risk would be 3 plus 4 or 4 plus 3, where 3 plus 4 would be low intermediate risk because it's the 3 is first. 4 plus 3 would be high intermediate risk because the 4 is first. And then there's high risk, which would be 4 plus 4, 4 plus 5, 5 plus 4. Hopefully we don't see as many of those, but we do see them.
Okay, I'm sure you do. Okay. All right, after treatment or no treatment, how do you follow? I want to go back to the testosterone thing. That's why if you get prostate cancer in your 40s, that's a bad thing because our testosterone levels are like off the charts when we're in that age group anyway. Well, not as high as they were when you were 18, but they're still high and they feed that prostate cancer. So are we still doing 50 as the time zone to test, or are we going back further?
So here's I was just looking at this on the AUA recommendations. Anybody with a family history of prostate cancer, like a father, uncle, 40.
Okay.
It's 40, and I've been doing that for 20 years.
Okay.
Black men, I usually screen earlier as well because of the genetics.
In the 40 area.
Like you mentioned, start around 40-ish. White men, it's usually more start around 45 to 50.
Okay. Interesting. I've been doing it since 40 in the specific cases. And I think soon we're going to have it coming out sooner than even if you don't have a family history because, cancer is just creeping up in our society terribly. And as we mentioned earlier, our diets stink. So, these fatty diets are leading to this problem.
The key to it is get screened. That's the key.
That is the key. Oh, okay. After treatment, how do you follow your effectiveness of your treatment?
Sure. So let me break that down into. Well, we already talked about active surveillance, right? And then for radiation, it's really the same for radiation or surgery, depending on how aggressive the cancer is. What I do is 3 plus 4 or more. I usually check them every 3 to 4 months for the first 2 years with a PSA blood test, and then after that, every 6 months until they're 5 years out, and then once a year after that.
And you'd like to see almost a non-detectable PSA, correct?
Right. So with surgery, it's going to come down to that, or it should come down to that right away. Right. We have to wait a few weeks because, again, PSA is just a protein. You have to get the kidneys to get rid of it first. So we wait, and then as long as that PSA is what we call undetectable or less than 0.1, we never have to do anything else.
Okay.
If it starts to rise later, we can hit them with radiation as a backup. Okay. Radiation is kind of the opposite. It'll start higher and then kind of come down lower, and then kind of turn into an asymptotic. You have to use that word, but it'll kind of level off eventually.
Okay.
And you may end up with a PSA that becomes undetectable also with radiation, and that's the ultimate goal. But if, say, you end up with a PSA of 0.2 for the rest of your life, I'll take that.
Okay, understandable.
Yeah.
Okay. Now, let's say you've taken care of the patient, you think its PSAs are good, and then all of a sudden you start to see the PSA rising, indicating that there's still some active cancer probably around, correct?
Not always.
Okay.
So you can have benign disease left behind that can do it.
Okay.
So I've seen people where, their PSA will start to rise a little bit, and then it'll stay at like 0.2 for a few years, and then at maybe 0.3 for a few years. So we look at the doubling time.
Okay.
How long does it take for the PSA to double?
Okay.
If your doubling time is 2, 3, 4 years, that's either very low grade or less aggressive prostate cancer or just benign cells.
Okay.
Because benign cells make PSA too, right?
Too, correct.
So now, if the PSA starts rising very quickly, then yes, it's more likely to be recurrence of the cancer.
Okay, so now you have a patient who's had a successful treatment, whatever treatment that may be. When do you consider doing a metastatic workup? You saw a little bit of a rise in the PSA. Maybe you imaged the area and you see that you don't see anything in the area through imaging. Do you do bone scans? It goes to bone and even goes to brain. When do you do a workup?
Sure. So again, that goes with that PSA velocity that I was talking about. How long is the doubling time? How long is it going up with a gentle slope, or is it going up very quickly? Very quickly, I would do what we do now is called a PSMA scan, which is it's a PET scan basically, looking for specific antigens or proteins that are expressed, and that's much better than the other things we used to have.
I agree.
Yeah, it's really good actually.
PET scanning is very good.
Yeah. This specific one for prostate cancer.
Is there one specific
that's
for that?
The PSMA, yeah.
PSMA.
Very specific,
okay.
yeah, it's good.
Right.
So, yes, that's what we use now, and we're doing a ton of those because we also do them preoperatively or pre-treatment to make sure there's no metastatic disease before we treat as well.
Well, PET scans are very nice, but they're very high in radiation. If you do a PET CAT. And, I see oncologists do them all the time on the person. Geez, are they going to introduce a myeloproliferative disorder by using that? You always worry about that. Okay. Like all cancers, any way to protect the men from developing prostate cancer? Any way that has been shown to prevent it?
So we talk about Mediterranean diet all the time, right? So we talked about diet earlier. Cancer likes sugar. It likes carbs, especially prostate cancer. So we always try to get people Mediterranean diets: chicken, fish, vegetables. Nobody's perfect, right? You're going to have that bowl of ice cream once in a while or a cheeseburger sometimes.
I understand.
You know what I mean? So, but those are that's what you can do. That, and there's really no way to necessarily prevent it.
Other than maybe dietary changes.
Correct, dietary changes.
We need a big dietary change in this country. We need some major problem. Everybody today in obesity or getting GLPs. Okay, that's a nice way to get started, but then you can't, maybe some are saying you can maintain them the rest of their life on that, but still they're eating the wrong stuff and letting a pill or a shot take care of their obesity or their overweight or whatever. That's not the way to look at it.
To me, that's like putting a humidifier and a dehumidifier in the same room.
There you go.
Right? So
that's the truth. It is the truth. It is the truth.
Yeah.
But, they make foods as such in our country, junk food, to taste so good. There's no doubt about it. I've had my Burger Kings in my day, and it tastes good, and
they're engineered to make you want more, too. A lot of those
and it sucks you right back to it.
Yep.
All right. A little bit about the genetics.
Sure.
How does genetics play into this whole thing? Is there any specific focus genetically that tells us this, or is it just my dad had it, my grandfather had it, my uncle had it?
I mean, sure, you can go see a genetic counselor. I don't do the genetic counseling myself. If I feel like someone needs that, I tell them, go see it. And one thing I do tell people, every time I diagnose someone with prostate cancer, I tell them, if you have sons or brothers that are 40 or over, get them checked, because if you're running families, and sisters or daughters, I tell them to get them checked for breast cancer because it's similar genetically.
The bracket.
Yep. And there's also, ovarian cancer, pancreatic cancer, colon cancer. Some of those can be similar too. So I kind of leave that up to the genetic people, but there's definitely a genetic
I
component.
fully agree
Absolutely.
with you because the genetics, I know that it's obviously genetic if it passes right on to every member of the male family.
Yep.
But, it would be nice to know, are you what is the BRCA 1 or 2 involved? And if it is, you tell your female patients that they have to watch out for it too.
Sure.
This has been a very interesting conversation, Steve. I appreciate your coming and doing this for us. I think I hope we weren't too technical for the non-medical people. But I'd like to make a comment before I say goodbye. It's critical that men over 50, possibly over 40, get a simple blood test called the PSA and a digital rectal exam to back it up and or find it by itself. When indicated for this potentially curable cancer, please see your primary care physician every year, get it tested, and catch it early before it could potentially become a killer. Again, Dr. Steve Terranova has given us a very interesting interview here today. I'm pleased. I think he did a good job. I hope it was good enough for the lay people to understand the importance of getting these tests done. Thanks a lot, Steve.
Thanks for having me.
No problem. And anyone who wants information regarding prostate cancer or any other urologic problem, you can reach Brandywine Urology through this number, 302-652-8990. They have offices in the north of Delaware and in the middle of Delaware, correct?
We're in Middletown and soon to be just near the airport.
Okay, very
the
good.
old Discover building. Yep.
You guys sign up if you need to see them and tell your family doctors to check you out. Again, this is Dr. Nick Biasotto signing off.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.